Welcome to a CNBC Africa special here in Kigali, Rwanda. Today the conversation is going to be on maternal health. Now, if you want to be part of this conversation, tweet us at CNBC Africa, or you can tweet me directly at The Real Quizera. Now, before we get into our discussion, I just want to give you a little bit of context. What is that? Now, in 2015, at the end of the Millennium Development Goals, it was discovered that 75% of the countries failed to achieve their targets. Now, another opportunity was given looking ahead to the Sustainable Development Goals, and we are a decade away from that. That's 2030. What is the progress so far in improving the health of women, in particular when it comes to maternal health? Now, I want to introduce you to our distinguished panel. Yes, it's a great panel of three brilliant women, and they're going to try and break down for us what needs to be done. You're watching CNBC Africa. To my left is Mark Jumise. She is the Chief Nursing Officer at the Mirabalaise Hospital, and she's also the Deputy Chief Operations Officer at the Mirabalaise Hospital as well. To Mark's left is Joy Mokaje. She is the Chief Medical Officer at Partners in Health and a professor at Harvard University. And to Joy's left is Viola Karanja. She is the Director of Nursing and Executive Director at Partners in Health in Liberia. Thank you for joining us. Now, I just want us to start there on regarding the Millennium Development Goals. Is that, and I'll start with Mark, right? Is that a half glass? Is that a situation of half empty or half full glass?
I think it would depend on what you are looking at and what countries you're looking at on the Millennium Development Goals. I think we have a long way to go, but I'm a positive person, or I try to be as much. I think on one point, we do have, in several countries, we do have a lot of improvements that have been made. So I do tend to look at it as half full, but I think there's a point where we can remain stagnant if we do not change certain policies and ways that we are doing care.
Joy, just to follow up with what Mark is saying, where did we get it wrong, and why did we fail to achieve those targets?
Yeah, thanks. So I'm also a glass half full person. We all are. We all work for an organization, Partners in Health, that really believes that healthcare is a basic human right and are willing to do what it takes to get that human right to people. We work with governments to assure the public provision of healthcare, and we work with communities so that the most vulnerable are part of the process and become part of our teams and inform the work. And I think where we really went wrong with the Millennium Development Goals is we set the bar a bit too low. A lot of work was done really to improve primary health care, which is great, and primary health care can really help children survive. We can find and treat a lot of HIV with primary health care. But what we can't do necessarily is save the lives of women with primary health care alone. We can't save the lives of newborns with primary health care alone. Why? Because when a woman has a complication of pregnancy, she needs a C-section, or blood, or antibiotics by vein, or all three. Those, what we call obstetrical emergencies, can really only be dealt with at hospitals. And so we believe at Partners in Health strongly, and I'm so delighted to be here with these two nurse leaders, that the skilled providers, particularly nurses, midwives, but also, frankly, surgeons, OBGYNs, are needed to really complete the provision of care. So where we really want to go now is say we've come a long way on primary care, but what else do we need to add to the package to truly assure that healthcare is a right? And both Viola and Mark work at that intersection between the hospital, the health center, and the community, and make that continuum of care work for women.
I'll come to you, Viola, based off what has just been said. You are one person who's at the intersection there. Do you also feel the bar was a little bit too low?
Well, I wouldn't like to talk too much of what happened in the millennium. I think now we need to focus with what we have now, the Sustainable Developmental Goals, and that's what we are at now. And for me, it's more now working and making sure that we achieve these goals that we have set for ourselves. I don't want to say they are low or high, I just want to say we can achieve by working together, as Dr. Joy has said, working together as a health professionals coming together, the nurses, the doctors, the midwives, because most of the times the nurses and midwives are left behind. But if they come into the wagon, then I believe we can. So for now, I don't want to talk about the millennium, which it's past, but I would like to talk about the Sustainable Development Goals that we are focusing now.
Okay, we're going to go to the Sustainable Development Goals. She's already getting a few steps ahead of us. I want to come back to you, Mark. Do you believe that what do you think can be done to reduce ill maternal health in developing countries?
I will tell you my opinion. This is my humble opinion. Many may concur or disagree with me. I think something that Dr. Mukherjee did allude to is the fact that it's a continuum of care. I think we look at maternal health too many times in silos. We look at it either it's primary care, ANC visits. We're focusing on how many ANC visits can we, antenatal care visits, can we get mothers to? But then are we looking at the community level of getting the mothers to the visits, right? Because yes, it's great to get them visits, but then you have issues of transport. That's a big issue. How many visits are coming in there? Or do you have other issues of they have other children? And if they have to choose between that child being sick and going to a visit, a sick child visit, and them paying also for an ANC visit, imagine how many times they're gonna have to pay for transport to come to that medical center. So we also have to think about how do we treat the family with the mother in there. Second part of you have to also think about of course, the prenatal care that we're providing mothers and the information that we're providing them to the point that they're able to understand it, not just throwing information, but are they able to well understand what we're telling them? The other part, and I'm just touching briefly on a lot of them, but the other part is the hospital part of it. Because once they come to deliver, is it respectful maternal delivery? Do we have the materials necessary to provide delivery? Do we have the surgeons ready? Do we have the blood ready? Are we able to provide that care for those obstetrical emergencies that come through? So going back a little, are those mothers recognizing those signs and symptoms of obstetrical emergency care to come to the hospital early enough so that we can do earlier intervention? For instance, in Haiti, our #1 cause of maternal mortality is eclampsia. Do they recognize
high blood pressure during pregnancy that results in seizures?
Right. Yes. So we have quite a bit of mothers coming in eclamptic seizures. So you're coming in late stages so that you're trying to do an intervention to save the mother and the baby. Now, and if you're looking for the continuum, again, post-delivery, are you looking at post-delivery care for the mother and the baby? Not just maternal care. Maternal care is maternal child care and the baby. And after that, are we looking at if it's a C-section or if it's a regular delivery, what infections, are we doing enough time for teaching for that mother to follow up? So when I'm looking at maternal care, because I'm a neonatal nurse, that's one of my specialties, I'm looking at that neonatal period too. Are those babies surviving? We know at least about 75% of the children that die within the first year, that die under 5 years old, die within the first year of life. What are we doing to be able to address that infant mortality and that childhood mortality within that first year? So it has to be a continuum of pre-hospital, community, hospital, and post-hospital, or that full follow-up if we're going to talk about maternal and family planning as part of it, if we're talking about maternal child health.
Dr. Mukherjee, Mark has noted quite a few challenges that are being faced there, but we're in an era where we're talking about AI, robotics, and collection, and there seems to be a fast forward there. But all that can be used in all different fields. Now, something like big data is very important, and the collection of data. How can it help in trying to solve some of the challenges that have been noted here?
I think it can help solve some of the challenges, but we have to say that it cannot solve all of the challenges. And I think there is almost a reliance on, well, an app is going to fix that, or big data is going to fix that. So we worry about that because I think at the root, and I hope Viola will talk a little bit about trying to get those newborn babies home and out of the hospital. That's something she's worked on with her team. Some of that is really around caregiving. We're here in Kigali at the Women Leaders in Global Health Conference, and one of the things that we believe women's leadership highlights is the need for caregiving versus a more technocratic solution, or at least using technical solutions within the giving of care. So, for example, if we're worried that mothers don't have transportation, sure, it is helpful if we give them cell phones so that they can call. We give them the right education so that they can call and get an ambulance or activate a network of people that can help them. But without the caregivers in that loop, it's going to be insufficient. So I think some of the communications things can help us, but I think at the end of the day, we have to really focus on caregiving throughout the continuum.
Viola, I want that example of what you are doing in the kind of conditions that you're doing it, that you're doing differently to try and tackle some of the challenges that have been noted by Mark.
Yeah, just like Dr. Joy have said, I know the infant or neonatal mortality has been quite high, and I know as Mark has mentioned about having supply equipment. Us as nurses, I'm a midwife also, we try to look at ways that we can actually help. Ways that maybe I may not need that incubator, I may not need that warmer. And those are the challenges that we had in Liberia, where we didn't have that. But what else can we do? Because again, we know that we had high mortality, teenage pregnancy, and with teenage pregnancy, what happens? We usually have low birth weight babies or preterm babies. And how do we ensure that these babies don't die? So, and we don't have those incubators. So we actually started something we call kangaroo mother care, where you don't actually need those incubators, but you can actually use the mother. Using the mother, that meaning putting the baby skin to skin and using, we call it a wrapper in Liberia, just tying the baby around the mother and teaching the mother to ensure that the baby is breathing, just to ensure that the baby is fine when the baby is on the mother. And that one can have actually helped. We have not collected data as per se to say that we have moved from this to this, but we have seen quite an improvement, because what we are doing, we started at the facility level and then we moved to the community. Again, we can't be able to have a mother stay in the hospital for more than 3 months, because at times you have to wait. At times a baby is born, we had a baby of 800 grams, and at times that will mean the mother staying there more than three months. And there are those challenges that the family will not be able to come and support this mother. So we have to discharge this baby. Maybe at that baby will be discharged at 1.2 to the community back home. But we have to ensure that the midwives are following, working together with the community health workers, we are following this mother at home, ensuring that the kangaroo care is continuing, the mother is well nourished, and also ensuring that the baby is well taken care of, that is at the right time, the baby is given immunization. What we have this strategy that we call it community nursing, where we have the nurses and the midwives going to the community. They actually have a small kit that they carry, the weighing machine, the weighing scale, and a few other thermometer, because it's good when you're going to see this baby who was discharged at 1.2, how are they doing? So you have to take the weight, you have to take the temperature, just ensure that the baby is well. As we do that, we're also encouraging the mother to continue taking care of this baby, how? Maybe breastfeeding, exclusively breastfeeding, and ensuring that the baby is kept warm, and how many hours, at least not less than 7 hours in a day, just to ensure that the baby is well. And we have seen that is working very well, because this baby currently is 3.5, and it's not the only baby that we have taken care of. I know if I had the statistics here, I could have shown you that we have actually achieved quite a bit because of that.
And that's with minimal resources.
Yeah, with very minimal resources. All we need is just the wrapper and just ensuring a midwife is following, and also using the community health workers, because those ones are in the community, just ensuring they're following.
It's a very emotional part, and I want to come back to you, Mark, regarding an issue. I'm a young man, and I come from maybe a different generation. There's been a lot of conversation regarding abortion. and the sexual practices and what's being advocated for, why is the right, or what is termed as the lack of the right to abortion, still an issue in 2019?
I think because it's become a political issue rather than a human rights issue, rather than a right to decide what's going on with your body, rather than looking at the effects that it has on that mother, rather than looking at what caused that pregnancy. Was it through violence, rather than looking at the health of the mother and the risk that it's posing to her, rather than looking at the issues that are happening within her home and what happens when you have an unwanted pregnancy. Instead of talking about these issues that are affecting the women, others are talking about what they believe and not speaking to the women directly, not listening to the voice of the women when they're saying. So you made it's become this more politicized issue that people are trying to either gain support for whatever their platform will be, rather than looking at what's the essential part is I have a right to decide what to do with my health, and I have a right to talk to my clinician that is following my health. That's between us. That's not between anybody else. And that has to be the essential. When we're making a decision, whoever's my clinician, it's me and my clinician making a decision based on my health. The ultimate choice is my health. It's me that's making the choice about my life. And that power is being taken away from women, and others are, it is a power struggle, I guess, in women. It's being taken away from women to make that choice.
How can we tackle that challenge of it not being a political issue?
Yeah. I'm not sure we'll ever tackle the challenge of it not being political. But what we're hoping, and this is one of the reasons that Partners in Health founded the University of Global Health Equity in Rwanda, and why we're here at the Women Leaders in Global Health Conference, we want to take the politics back. And say that, women should have a say. And I think if there were more women that were policymakers, if there are more women who are listening and collaborating with other women, that we would have more control over the debate itself. So unfortunately, I think women's lives and women's bodies have always been politicized. And so what we're hoping as a consortium of women leaders and universities that highlight equity, which means gender equity as well as health equity, that we will become part of a more progressive political process where human rights is central, where ethics and sort of equity are central. And one of the things I teach about at UGHE, but at Harvard as well, is the notion of feminist ethics means that the moral experience of women is highlighted. And so as Mark's saying, we've had so many young women, older women, very poor women that we care about deeply. And their experience should be much more central than somebody's political view. And so what we're looking at is really trying to change the politics toward caregiving and toward proximity. And that's what we consider a kind of set of feminist ethics that will deliver actually equitable outcomes instead of these very highly inequitable outcomes that we have now.
Just to piggyback off something you highlighted there, and I want to stick with you with that. Why is it important to have more women in leadership positions in the health sector?
Well, I'm of two minds of that, because I think if we just put more women in leadership and leadership remains extremely hierarchical, it won't give us the outcomes we want. We want better outcomes, more equitable outcomes, better human rights. But what I think is, and many studies have borne this out, that women in leadership positions tend to be more collaborative, more ability to listen, more ability to work across disciplines, across social classes. And so what we want as a collective is women in leadership positions, but we want the way leadership happens to be a much more inclusive, intergenerational, interdisciplinary kind of leadership that will really put the people who are vulnerable, women, the people who are the recipients of the programs and the care, that they're part of the dialogue. And so what we're hoping is that more women in leadership will also change what leadership looks like and make it closer to the ground.
Mark, before I come to you, Viola, we keep talking about, so many a time at these conferences, we keep talking about more policies and stronger policies, and we need to do better with it. With the policies is a term. But there is a belief, and that let's move away from just talking about the policies. What do we need to do to ensure even the current policies action is taken?
Oh, you're asking a very simple question. No. I believe one thing that we always say, the person closest to the patient is the one that has the most information. We have policies that are so removed from the person that somebody can identify and say, in all good intentions, not bad, all good intentions, saying like, this is what should be done, but without real, without enough input from those that are closest to the patient. I think policies are great and it's a guideline, but I also think that we need to review and see how it's been applied. Is it too broad? Are we looking at what's happening on the ground? Are we looking at are we looking after a year or two what is working and say like, this policy just does not work for us right now? And who else should be at this table before we decide to change the policy? Because what happens is, from what I've seen in my limited view sometimes, is that policies are made. If we see it's not worked, policies are reevaluated and remade, for a better word. But then it's the same people that made the policies that are changing the policies, but then you haven't said like, wait, if it did not work the first time, what's the missing link? What's the missing piece? That could be that midwife, that physician at the bedside, that nurse that's at the bedside, the community health worker. These are what works. When we were developing, just to go off, we were developing a program called J9, All My Heart. It's an accompaniment-based program. We accompanied mothers throughout the pregnancy and then at least 1 year after delivery with her mother and baby accompaniment. There's so much more to go into this program, but one of the things that we did in that, because there's a heavy community-based part, instead of us saying like, oh, this is what should happen in a community based on our limited knowledge of going out into community, no, we call the people that are actually working in the community and say, what should we do? And they brought in the limitations that we did not see, that we had to put, before we pulled out this program. They were like, that's not going to work. It sounds great, but that's not going to work in realities, because we're the ones that actually walked the ground to get to these communities. These are your barriers. We need to look another way. Because if we stayed at the people that are in the office or in the hospital and not brought in the community, we're going to see it one way. Just because I went out on a community visit and did a couple of community visits, I don't work it every day. And I don't know this community that's different from this community, that's different from this community. But those community workers, health workers, that worked in this section and this one that worked in this section, they know their sections. Bring them to the table and tell me, nope, if you go in this community, this is not going to work. You're going to have issues you have to think about different. Who's at the table making those policies? That's what makes policies work or don't work.
Well, I seem to agree with a lot she says. And you're on the ground. Yeah. Do the nurses and the midwives you deal with on a daily feel some of this, they're left out of this policy conversation and would like to have a change in what is spoken about?
What I can say, it's quite true. Most of the policies that are written, the nurses and the midwives are left out, so that someone on the table does write the policies on the higher level, and they.
But companies are hired for a year to do research on these things.
Yeah, so now again, it doesn't come to us on the ground. But what I know. What we're actually doing as PRH is taking these policies and having training people and having mentors to ensure that these policies people know them up to the ground. Where someone teaches, maybe take a policy in regards to, let's say, something to do with maternal child, and then trickles down, comes down to the level where he teaches, and then we leave a mentor to actually mentor and ensure that this policy is on the ground. Unfortunately, now, if at all we're in the time of review, they don't call us back to come and give our feedback. So that's what I was agreeing with her. It's quite true.
Can I,
Yes,
sorry,
please.
can I respond? Can I just give you one example of that, exactly what Joya is saying? One, we had a woman in a community that when we went to do home visits for this particular community, we went into one mother's home and her blood pressure was like 240 over, I think it was like 180. Her hypertensive crisis, had jugular vein distension, was having classic signs of double vision. And then we were like, you're coming with us, we need to refer you to the hospital right now, having headaches and so forth. She's like, husband was working out, had 3 kids at home, and said, I can't leave my kids. Who am I going to leave? She knew the signs. She was in the program. She understood the signs.
Yes, it's not that she doesn't know.
She didn't know, but she could not leave her kids. And so at this point is, what do you do? So we helped at that moment where we're like, we'll bring the kids, we'll put them here, we'll watch the kids for you, we'll make sure, whatever it needs to do. But that was for this one mother. The question that we had, we brought her to the hospital. Immediately she was admitted. And we watched the kids until we could find somebody else in the family to come there. But the question came back to is how many other women, not just for this one, how many other women are facing this decision? So now what do we have to do is start asking that question.
Right. Because that's what should inform policy, right? What should inform policy is the best possible caregiving for this type of situation. And then the policy should be formed around that, so that you need to figure out a child care strategy. If you want a woman to come in, you could put that in policy. But nobody thinks about that because it's too complicated.
Unfortunately, this conversation has to come to an end.
Well, thank you for taking the time.
It's such a great conversation, very emotional on my part, a lot to learn. Thank you very much for having your time with us. That's the end to this conversation on maternal health. Now, for more on this, you can tweet us using the hashtag at CNBC Africa, or follow me on Twitter directly and be part of it at The Real Quizera. Our panelists, again, Mark Jumise. She is the deputy CEO, she is the chief nursing officer at Mure Balais Hospital. To her left is Dr. Joy Makaje. She is the chief medical officer for Partners in Health and also a professor at Harvard University and University of Global Health Equity here in Rwanda. And to her left is Viola Karanja. She is the director of nursing and executive director of Partners in Health in Liberia. Thank you.